Good evening, dear colleagues. My name is Mohamed Youssef. I'm a consultant orthopedic surgeon in Herford, Germany. I would like to talk about the indication and limitation of the subacromial impingement syndrome. By the way, I like to call it subacromial impingement syndrome and not impingement syndrome because there is another impingement in the ankle joint and hip joint. Okay, the subacromial impingement syndrome is the most common disorder of the shoulder, resulting in functional loss and disability in the patient that it affects. Neer divided the impingement syndrome into 3 stages. Stage 1, edema and hemorrhage usually occur in the patient below 25. Stage 2, fibrosis and tendinitis with a typical age of 25 to 40. Stage 3, bone spurs and tendon rupture in patients above 40. Causes of subacromial impingement syndrome: intrinsic mechanism and intrinsic mechanism, muscle weakness, repetitive microtrauma, degenerative changes of the acromion, extrinsic mechanism, shape and gradient of the acromion, scapular muscular paralysis. Classification of pathomechanics of impingement syndrome: outlet impingement and non-outlet impingement. The outlet impingement is anterior acromial spore, shape of the acromion, slope of the acromion, prominent at the joint. Non-outlet impingement: prominent greater tuberosity, loss of the head depressor, loss of the glenohumeral fulcrum, loss of suspensory mechanism, defect of the acromion, thickened of the bursa or cuff, loss of the lower extremities, abnormal use. So treatment option and indication: as usual, the goal of treatment is eliminate the pain and restore the joint function. Conservative treatment: in absence of the major damage, conservative multimodal treatment for 3 to 6 months is the initial therapy of choice. The anti-inflammatory: regular administration of the anti-inflammatory drugs for 1 to 2 weeks to reduce the pain. Physical therapy: mobility of the joint should be gradually increased, loosening, massage, and physical measures including heat or cold application, electrotherapy as iontophoresis, and exercise pools. Corticosteroids injection, very important to improve the mobility and reduce the pain. Shock waves therapy is used to treat calcific tendinitis. High energy shock waves lead to the disintegration of the calcifications. Exercise: once the acute pain has been treated, emphasis is placed on the physiotherapeutic measures for mobilization. Approximately 30% of the patient undergo surgery. After ineffective conservative treatment, surgery is indicated after 3 or more months of the conservative treatment. So, subacromial decompression that involves removal of the anterior and lateral portion of the undersurface of the acromion, 5 to 8 mm, and detach of the coracoacromial ligament. Neer published the anterior acromioplasty procedure as a treatment for impingement syndrome by making a wedge resection of the anterior acromion and upper third of the coracoacromial ligament. He indicated that the surgery is done only in the case of failed conservative treatment for a period of 1 year and having a positive impingement tests. Elman, 85, described the technique of the arthroscopic subacromial decompression by using an acromonizer to resect the anterior acromion protuberance and the osteophyte to achieve a larger subacromial space. The position of surgery was in a lateral position on the pitch chair or sitting position, of course. So the indication of anterior acromioplasty, outlet impingement, according to Neer, 83, when repairing an impingement tear, more than 1 year, pain with conservative therapy, occasionally stage 2 with acromion. Non-outlet impingement, greater tuberosity, malunion. Arthroscopic guidelines modification by Ellman if the space less than 12 mm, more than 6 months for second stage impingement, positive bone protuberance and spore with stage 2 protuberance bone, and for the arthroscopic non-outlet is only of the if the tuberosity to be below the head level. So I would like to show you the video here. We can see the acromion and of course the supraspinatus tendon with coracoacromial ligament. Here we can see also the bone spore and friction between the bone spore caudal to the acromion, and we are going under the acromion spore with acromionizer, dissect the bone spore to achieve a place between the acromion and supraspinatus tendon. Okay. I would like to show some picture for Professor Neer and his open arthroplasty, acromion protrusion, and also Ellman for the arthroscopic lateral decubitus position and semi-sitting position, and also the sitting position. So the controversies, both open and arthroscopic subacromial decompression outcome are consistently reported very good results. Different recommendation of when to do surgery are present in the literature, either following non-operative treatment for at least 6 weeks, 3 months, or 6 months, or 1 year also. Some recommended that decompression should be done with all rotator cuff tears. Others did not recommend that at all, as recent studies suggest. How to deal with the coracoacromial ligament? Complete resection, partial resection, or non-resection. Controversy is doing subacromial decompression in a case of calcium, workers, compensation, and partial rotator cuff tear. Yes or no? Question mark. The acromion shape. Okay, here the acromion shape, I would like to show the difference between the flat, curved, and hooked acromion, and also between the coracoacromial ligament. Here are also the space between the acromion and the tendons, and acromion and humerus bone. An arthroscopic and radiological study was done on 410 cases who underwent a subacromial arthroscopic surgery in the shoulder hospital bone. An arthroscopic evaluation of the space between the anterior acromion and the rotator cuff, the AAC space, and the radiological assessment of the shape of the acromion and the space between the anterior acromion and the head, called the AH space, was done. Classification of the space between the anterior acromion and the rotator cuff supraspinatus tendon, AAC space: 133 impingement tear, 156 impingement stage 2, calcification with 97, instability impingement 24. The purpose of the study was to assess the relation between the rotator cuff tear and the shape of the acromion, the size of the radiological anterior acromial space, the size of the anterior acromial cuff space, and the relation between the shape of the acromion and the AAC space, and the relation between the radiological anterior acromial humeral space, AHA space, and the AA space. The arthroscopic study is done with a patient in sitting position and the arm hanging as standard for measuring the AAC space, and by using two measuring needles, one placed on the medial and one in the lateral corner of the anterior acromion for space measurement. The space between the anterior acromion and the rotator cuff AAC space was classified to 4 types. Type 0, where the space is more than 12 mm, type 1 with the space between 6 and 12 mm, type 2 between 1 and 6 mm, and type 3 less than 1 mm. So the evaluation of the relation of the space measurement to the pathology showed that in type 0 with a space of more than 12 mm, there was mainly instability impingement cases where the narrowing is only dynamic. An outlet impingement, rotator cuff tear, and impingement stage 2 was not found in the type 0, but mostly type 2 and 3. So, based on this study, there was almost no outlet impingement pathology when the space was more than 12 mm or type 0 AA space. Analysis of the 133 cases of rotator cuff tear showed an average radiological AH space 7.9 mm, an average AAC space 6 mm. A spore formation on the anterior acromion was present in 17 cases, a flat acromion in 28%, curved in 38%, and hooked in 34%. Comparing the recommendation done in the era of open decompression and the rotator cuff repair to the arthroscopic possibility of treating impingement, nowadays we can present the following based on the measuring needle technique knowledge. So in repairing rotator cuff tear, decompression is only done when the space less than 12 mm, not for all cases. So our experience showed that 6 months of failed conservative treatment with the modern physiotherapy for impingement syndrome without cuff tear is an indication for arthroscopic decompression, and not 6 weeks or 12 months. All other causes of non-outlet impingement are only treated with arthroscopic decompression when the AAC space measures less than 12 mm after treating the non-outlet impingement cause as removal of the calcium or treating a greater tuberosity pathology. Take-home message: in case of outlet impingement, decompression is only done when the subacromial narrowing is less than 12 mm. In case of non-outlet impingement, treat first inferior cause narrowing, the measure the space to see if the subacromial decompression is indicated if the space less than 12 mm. Thank you very much. Thank you for your attention, and sorry for extension.